record this session, just to let you know. Uh, Thanks for joining us today for the presentation on illicit drug trends and why it matters for patient care. I'm Professor Valerie Harder. I'm a mental health epidemiologist here at University of Vermont, and I lead our surveillance and evaluation core for the UVM Center on Rural Addiction. I'm also the Vermont site lead of the Tracking and Evaluation Core of the Northern New England Clinical and Translational Research Network. So a few reminders, please mute yourself until the Q&A session, and also put your questions in the chat as we go through the presentation. And as I said, this is being recorded, so you can visit our website to view a recording of the session, send it on to your colleagues afterwards. So today's presenters, Dr. Reiser, Stephanie Thompson, and Dr. Sterner, they'll discuss recent trends of illicit drug supply across our geographic region, the Northeast, and we'll explain how drug supply affects patient health and how tracking drug trends can be a useful tool to guide the development of interventions. Dr. Reiser is an assistant professor of medicine, hospitalist, and addiction medicine physician here at the University of Vermont. And she is the inpatient director for the Start Treatment and Recovery program across the UVM Health Network. This is an innovative program for treating opioid use disorder in hospitalized patients. Stephanie Thompson has a master's degree in public administration and is the public health analyst for Vermont with Overdose Response Strategy. And her work focuses on emerging drug threats, complexities of co-occurring substance use and mental health challenges, and working in multi-sector partnerships to address substance use and crime. And finally, Dr. Sterner is an associate professor of criminal justice in the College of Social Work at the University of Kentucky. His research addresses substance use issues, human trafficking, and gambling impacts. And one of Dr. Sterner's projects is to develop predictive early warning systems for addressing emerging substance use issues in communities. So I'm pleased to welcome these three excellent researchers to our seminar series today.
Thanks, Valerie. Stephanie, do you want to get started and I'll change the slides?
Sure, that would be fantastic.
Okay.
So we have no financial disclosures or conflicts of interest today. So some of the things that we're going to cover during our time together is looking at some of the recent trends around the illicit drug supply in our area of responsibility or in Northern New England, looking at and understanding the clinical complications of both active and inactive adulterants within our drug supply, and looking at some of the different methods for drug checking and data sharing that exist in our area. Next slide. All right. So here we have some overview data of Vermont overdose fatality deaths through 2024. You'll see that over the last couple of years, our numbers have gone down. We're down about 22% in 2024 over 2023. Vermont is in the top 10 for age-adjusted overdose death per capita, and we have continued to see an increase, and we'll talk more about this as the presentation goes on, in the involvement of cocaine within our overdose fatalities. Xylazine also has significant prevalence. About 32% of our overdose deaths in 2024 involved the substance xylazine. And then we also noted that only 5% of our overdose deaths have involved just a single substance. So polypharmacy is a critical factor in the fatalities that we're facing. Next slide. So this shows the data through June of 2025, which is the most recent data that we have. Vermont does have about a 3-month data lag for our fatality data, and even then it still remains preliminary. So we're at 45 through June of this year. That's about 44% down from where we were the same time last year, and about a 50% decrease over the 3-year average. Next slide. So this kind of shows the fluctuation that we see from month to month across the state, and in some of the conversations with our partners, we definitely saw an increase in different areas in May. That does tend to be relatively common. And then here in the chart on the right-hand side, you see the breakdown of our substances that are involved in our overdose fatalities. Fentanyl continues to be the most prevalent driver of the fatalities. It's worth noting that over the last few years, we have started to see prescription opioids being involved in more fatalities than we had in recent years, severely overtaking heroin. I think right now we've only had three fatalities that involved actual confirmed heroin within the state of Vermont. Next slide. And this is just a little bit more granular breakdown of some of the additional substances that we're seeing within our supply. We had started tracking gabapentin involvement over the last several years. We had seen a pretty large uptick in that. That has decreased a little bit over the last year or so. Um, Benzodiazepine involvement remains pretty steady. Methamphetamine, it tends to bounce between about 5 and 10% over the last 10 years or so. So we're seeing that to be pretty consistent from what it has been. Cocaine, there you see, is involved in more than half of our fatalities. So that is something that we're continuing to be very vigilant of in the involvement of stimulants within our opioid supply. Next slide. And here we see the percentage of cocaine over time in our opioid overdose supply. You'll see how this line, to me, really calls to the when we started really seeing the uptick in fentanyl. It kind of is a very similar trend line. So 55%, as I had mentioned, is right now where we're at through June, which is looking at a rate of a lower percentage of involvement than last year. But of course, we also know that we do not have a full data set. Um, this is really speaking to kind of another wave of the overdose epidemic. And, it's a trend that we've been seeing kind of across the region. I will note that in some of our seizure data for this year through yesterday, we are also seeing a dramatic increase in stimulant involvement in our seizures, cocaine being the most seized, and a large majority of our seizures being polydrug with both cocaine and fentanyl being captured. Next slide. All right, so some of our drug checking data. Vermont has been very fortunate to enact some work around drug checking. We had the opportunity through New England HIDA, who I'm associated with, and the Brandeis University. We received some discretionary funding from the Office of National Drug Control Policy back in 2022. We were able to onboard one of our harm reduction programs, the AIDS Project of Southern Vermont, which is right along the Interstate 91 corridor. The purpose of this project was to really look at drug trends at the street level through that corridor. So coming up through Connecticut into Massachusetts into Vermont. This is just a little sample of what we saw over the 2 years through November of last year with our testing. So you can see, similar to our fatality data, very high prevalence of fentanyl. We've had some of the more novel analogs, cocaine you see there, xylazine, that very low number around heroin, and medetomidine starting to appear as of last fall. There very little samples tested positive for heroin. Again, that's not a surprise based on what we know about our current drug environment. And this, like a lot of data sets, is just a sampling of what we're seeing in our supply. 135 bags is a relatively small sample size, but for a state that didn't have this previously, having this information and being able to provide that to people who use drugs has been a very valuable opportunity. It's a very good harm reduction practice, and there's also that secondary benefit of folks that are going in and getting tested, getting their substances tested, being able to share that back to other folks who might be utilizing a similar supplier. I think one of the other things that I would highlight is in 2023, the state of Vermont did start funding drug checking programs across our harm reduction services in Vermont. So all four of our harm reduction programs now do drug checking in some level. Still kind of waiting to see what comes out from the state level with some more robust reporting. But this is really good information, and we try to get that out. Not that's our public health, but our public safety partners as well. Next slide. Similarly, here is some additional drug checking data. This is a site that had come on a little bit later, so they came on after that funding through the state. This is out of the White River Junction area. You can see in bold some of the the substances that I think are, worth highlighting. And I won't go into detail because we are going to, Ellie's going to go into some more specifics about these substances a little bit later in our presentation. But, you're seeing the xylazine occurring. We got fentanyl. You're seeing cocaine in these samples a lot, the medetomidine as well. I do want to make a note about carfentanil. We had been very fortunate in Vermont that until recently, we really had not seen carfentanil involvement. So while we thought we maybe had kind of dodged that one, unfortunately, it has found its way back into our supply. Generally, we're seeing just a trace, but where there's a trace, there's the high probability that there is more in other samples. Next slide. So just of those 14 samples that were highlighted there, we see the breakdown here of what was in those. Some of the other things that are worth noting, weird benzos, things that are not approved for human use, phenacetin, the nitazines, again, the carfentanil. So things that can be relatively novel or that the individual user may have less familiarity with how they are affected by it. So it can also increase the not just the risk of overdose, but of other health complications. Next slide. Great. So we have done some work with Dominion Diagnostic. They do a lot of the urinalysis testing for our treatment programs. They are the predominant tester for the Vermont sites, and we'll also see some data from a couple of our other New England states here. So this is samples of individuals who are on MOUD. You're seeing, of course, your buprenorphine, which you would expect. I think it's worth noting that antipsychotics are very common. We're seeing that across both of those other states as well. It's often used with MOUD to treat co-occurring mental health conditions that, can be pretty significant in the population with substance use disorder that have, dual diagnosis or comorbidities. So again, here you're seeing some more of the different stimulants, the methamphetamines, you've got your benzodiazepines, pretty low level of barbiturates, but we are still seeing that in some of the samples. Next slide. All right, so this is the same data for New Hampshire. This is just looking at quarter 1 and 2 combined. Similar story. We're seeing the stimulants, we're seeing antidepressants, we're seeing opioids that are not the opioid antagonists, and those antipsychotics. Next slide. Very similar story here with the data out of Maine. The dissociative medications, I think, is a little bit more prevalent in this population than we had seen in the other 2 states. And next slide, and I think that's you, Ellie.
Thanks, Stephanie. So what I kind of take from all this is that my patients do not have access to anything predictable in the drugs they're buying on the street. The drug supply is really trash, and for that reason, it's dangerous for my patients. They're unlikely to know the potency of the drugs they're buying, meaning how much of a drug produces an effect, or the purity, meaning how much of that active substance is in the bag they're using. And this is a formula that's used by the Philadelphia Department of Health, and they do a great job sort of making public pretty up-to-date data on what's going on with street drugs in their city. And what I want to emphasize with this slide is that the potency index, which is a calculation where they take a potency factor, which arbitrarily they made 1 for fentanyl. So for carfentanil, I think it would be 100, and then the purity of what's in a sample, and thereby are able to compare potency of bags with different substances in it. And what you can see in those little red pill-shaped ovals at the bottom is that the opioid potency across samples can be orders of magnitude different. And so you can imagine what kind of risk for overdose that poses for patients, particularly if they're polysubstance use involved. So this brings us to xylazine, which isn't really a novel substance in our drug supply anymore at all. But it has taken, at least in the medical community, quite a while for us to catch up to what is going on the streets and what we're seeing with our patients in terms of overdose syndromes, withdrawal syndromes, complications of use. And xylazine is a really good example of that. It's been in Vermont for years. I think it was first sort of regularly found in the United States around 2008 or so. So it's been around for a while. It's an alpha adrenergic agonist. So there are several types of these medications which we prescribe. Clonidine, for example, sort of a third line antihypertensive. Dexamethasone is something that's used in our ICU as a sedative. Xylazine is not approved for human use. Many years ago, Bayer tried to bring it to market, did a good job of lowering blood pressure for people, but they also noticed that they were blacking out and, didn't remember what happened, and so it never came to market. But they do use it frequently in veterinary medicine, particularly for large mammals, horses and cows and that kind of thing. What it does when mixed with opioids like fentanyl is that it potentiates those effects. So the fentanyl, typically the euphoric effect is pretty short, on the order of like an hour or less sometimes. So it can prolong that and make it more intense, but people are more likely to sort of black out. It's found, I think, most recently in about 40% of our overdose deaths. Um, and it's associated with these soft tissue wounds, which you may have seen or may have heard of. And then also with a withdrawal syndrome, which is complicated in the hospital when we're managing someone who's withdrawing from fentanyl and we're treating that, but they don't get better. It's because they're also having another withdrawal syndrome from an alpha adrenergic agonist. It's called trank or trank dope on the street sometimes. So xylazine overdose and toxidrome can look like CNS depression. Hypotension and bradycardia are like some of the big features. People can get hyperglycemic, pupillary constriction, and it's not associated with the kind of respiratory depression you would see with opioid overdose. However, it may be that people are so sedated they're unable to protect their airway. And then the wounds are often start as like small ulcers or necrotic spots, and they can grow to be quite severe. I've had patients lose limbs because of the severity of these wounds. We don't totally understand the pathophysiology. It's probably multifactorial, so it's thought that there's local vasoconstriction, and this is regardless of the method by which people use it, smoking or injecting. However, people who inject repeatedly often have problems with their veins. They have venous insufficiency or lymphedema, poor wound healing, and you can have extravasation of the substance that's being injected. So it's probably a combination of all those things. And I should also mention in Vermont, and I'm sure in everyone's states, some of our harm reduction agencies have wound care kits as a way to help prevent these wounds from getting worse. They can be treated, but it's hard if people continue to inject. It makes that a lot harder. And I want to emphasize from my perspective as a hospitalist, I see a lot of indirect complications from these substances and from people, being so sedated that they're like slumped over like this person in this picture. So I've had patients with rhabdomyolysis or limb ischemia, blood clots, pressure injuries, exposure, to heat, cold, frostbite. And it's not uncommon for me, particularly in some of the female patients I take care of, to say, if they're living outside or something, they feel unsafe at night. And so they'll use stimulants to stay up all night out of like a mechanism to try to protect themselves. I'm going to skip this slide, actually. So this brings us to some emerging trends we're seeing. And we mentioned earlier medetomidine. It is in the same class as xylazine. It's an alpha adrenergic agonist. It is also used in veterinary medicine, similar way as xylazine. It's actually a racemic mix of levomedetomidine and dexmedetomidine. And if you recall earlier, I said we actually use dexmedetomidine quite frequently in our ICU. So it's pretty potent. It's like an IV drip, and we use it for sedation typically. This drug is not associated with soft tissue wounds like xylazine is, but we are seeing that when people are using this on the street, it seems that their withdrawal syndrome is more severe than with xylazine, often requiring ICU admission. And in Philadelphia, as of this summer, xylazine was actually less common, or medetomidine was more common than xylazine in their drug supply. So I sort of wonder if this is a trend we'll start seeing in other parts of the country as well. And anecdotally, I met last month with all of our opioid treatment program clinicians, our methadone clinic clinicians, and they have been seeing much fewer xylazine wounds. So I sort of wonder if things are evolving. This is an M&M report from May from the CDC, also from 3 hospitals in Philadelphia, 165 patients. I think it was between the end of 2024 and like April or something of 2025. They had 165 patients that were hospitalized with fentanyl withdrawal and what initially seemed like probably a xylazine withdrawal or alpha adrenergic withdrawal, but they had very profound autonomic dysfunction. So severe hypertension, hypertensive emergency, tachycardia, agitation, but it wasn't responsive to the typical like on the floor measures you'd use to manage this kind of withdrawal syndrome. People had to go to the ICU, and they required a dexamedetomidine drip to control their symptoms. Also, it seems through the information I read on the Philadelphia Department of Health website, it's associated with tremulousness, myoclonic jerking that could be confused with a seizure, and encephalopathy. So people can be waxing and waning, agitated, and then, confused and that kind of thing. A substance that's relatively new to my understanding, I recently learned about this, is BTMPS. I'm not even going to try to tell you the actual scientific name, but it is an industrial compound. It's used in adhesives, sealants, plastics manufacturing. It is not approved for human use. I couldn't find any data on physiologic effects in humans. There are some animal studies, and it doesn't seem to be good. So cardiotoxicity, sudden death, none of those things sound good. And why it is now in the drug supply, we aren't totally sure. It could be used as a bulking agent, like many substances and cuts are. There is some thought that perhaps it stabilizes one of the fentanyl precursors, 4A-NPP, I think it's called. So maybe that's why, but we're still just beginning to understand about BTMPS. So this is from a JAMA article from earlier this year, looking at 9 community drug checking sites. So where people bring in their sample of their own accord and have it tested, usually with mass spectrometry. And what they found was that between Los Angeles and Philadelphia, there are 284 samples of all with fentanyl, and of those, about 35 had BTMPS. And of those that had BTMPS, 63% had more BTMPS than fentanyl by volume. So not uncommon in these cities. And then high potency synthetic opioids. I wouldn't say these are novel, but I think the trends are ever evolving and changing. So we all have heard about fentanyl. It's quite potent, so about 100 times more potent than morphine. For example, heroin is approximately 3 times more potent than morphine for comparison. Carfentanil, as Stephanie mentioned, is a little goes a long way, so 10,000 times more potent than morphine. And you can imagine if you're trying to dose control in an illicit supply, like that can be very dangerous. It's not that any of these drugs are better or worse than the other, they just have different features. So it has a high affinity for the mu opioid receptor in the central nervous system, meaning it binds really, really tightly. And that has implications not only for, the biggest implication in my world as a hospitalist in managing patients with opioid use disorder is it makes initiating buprenorphine a little more complicated. So one of the 3 medications that are FDA approved for treating opioid use disorder. And it's pretty short acting, as I mentioned before, so the euphoric effects are rather short. Another high potency synthetic opioid class are nitazenes. They're different, totally different than fentanyl or U series analogs or another kind of group of sort of designer, I guess, opioids. There are a whole bunch of uh, different analogs. So this is like a very short list here, but they're also more potent than fentanyl. In Switzerland, they tried to bring these to market, but they never were approved for human use. And I think they're just used kind of in like pharmacologic research now. And they begin to appear in the illicit drug supply around 2019. They actually aren't scheduled substances in the US, which I found surprising. And then we have the weird benzos, as I call them. They're designer, they aren't FDA approved, they're illicitly manufactured. They act like other benzodiazepine on the GABA receptors and cause sedation, just like, Ativan or diazepam or any of the other approved benzos that we use. They're often more potent than the benzos that are FDA approved. They have long half-lives. Some people even report effects up to 3 days. And we know that combining benzodiazepines with opioids can cause like a synergistic toxicity and really increases the risk of overdose, death, respiratory depression, those things. And benzo withdrawal, similar to alcohol withdrawal, can be very severe, even life-threatening. And these medications are highly addictive. And this brings us to adulterants. So that sort of adulterants are cuts or inert fillers that are put into the active substances. Um, the problem with these adulterants is that people may compensate because they're feeling less of the effect of, say, the fentanyl they're wanting to use. So they may use larger amounts of the drug and increased risk of overdose, or if they have greater kind of exposure to the adulterants. And also adulterants may affect the pharmacology of the active drug. For example, the particle size or solubility, how it burns, how it absorbs. And the adulterants sometimes have toxic effects on their own. I don't intend you to read this entire slide, but this is just a sample of some of the common adulterants we see. So mannitol is, we use this as like a hypertonic fluid that we use to manage increased intracranial pressure. For example, in the neuro ICU, it draws fluid out of the brain. It also causes diuresis through the kidneys. So you can imagine if that's something you're injecting like without intention of having those effects, you could see how like there are a lot of uncontrollable factors that could hurt people. Lactose, levamisole. I have a slide on levamisole. That's a big one. It's found most commonly in cocaine. Actually, it's found quite a bit in cocaine. I think also some in opioids. It's used as a bulking agent, but it also is thought to perhaps potentiate the effects of cocaine. And it passes, I guess there's like a street test. They use bleach or something to determine the purity of cocaine, and it goes under the radar. It can like pass that test so it doesn't show up as a cut in this way. But it's associated with serious health risks. Phenacetin, Stephanie mentioned, it was once approved, I think in the 70s, kind of like Tylenol for fever and pain, but they found that it was nephrotoxic, carcinogenic, all kind of bad things, so it was taken off the market. And levamisole is actually also a veterinary med. It's a dewormer, and it is associated with this vasculitis. And I've actually seen multiple cases of this. I've probably seen about a half dozen cases over 8 years in Burlington. The vasculitis characteristically affects the ears, face, nose, and extremities, and it's these purple kind of purpura like the picture on the right. The treatment is easier said than done, which is to discontinue exposure to the drug. And I believe that data is from, yes, 2017, almost 90% of the bricks of cocaine seized by the DEA had levamisole in them. All right, Glenn, I'll pass it over to you.
Thanks, Ellie. And so we've really been intentional about talking about some of the adulterants, some of the novel psychoactive substances that might be coming into our illicit supply, as well as some of the official sources of data. And so, one of the questions that we always have is, how do we identify when additional novel psychoactive substances or additional adulterants are present within our substances, particularly in the illicit supply? And there are a couple of alternate sources of data that we can actually utilize that are really helpful, what we would call initial indicators that something might be occurring. And so these are what I would consider early warning signs of potential issues that might be spreading across geographic space. One of the locations that we get some of the information regarding the emergence of certain issues is through the poison control centers. And actually in Pennsylvania, so for those who are not aware, I just recently moved from Pennsylvania to University of Kentucky, so I have a lot of reference for the work that we've been doing in Pennsylvania there. And so in Pennsylvania, that was actually where we identified early on that we were having an issue with gabapentin because it was presenting within poison control center data early within the city of Philadelphia, but also then subsequently in the city of Pittsburgh. And so, next slide. These data help us to identify on a national scale some of the issues that might be present across our various supply issues. And if you can just click, Ellie. To highlight a couple of these, this is a specific table that identifies some of the growing issues, the greatest rates of exposure increase across the past year. And we are seeing that unknown drugs and stimulants and street drugs, as well as miscellaneous drugs, are continuously growing within the issues associated with the poison control center data. Next slide. And Ellie, if you can just hit the so we also identify that within adults, stimulants and street drugs, as well as miscellaneous drugs and unknown drugs, make up roughly about 5 to 7% of the presented cases associated with poison control data. And so the data that is available can be uh, located for across the various poison control centers. And so if you want to get more granular data, you can access this through connecting with your poison control centers that are specific to your locality. Ellie, next slide. And Stephanie talked a little bit about some of these other sources of data, specifically from the street drugs that are being checked through what we would consider drug testing or checking initiatives. And these are slightly different than what we would typically see with regards to harm reduction types of interventions. These are individuals who bring substances to have them actually screened or tested to a specific location, or there's also opportunities in some locations to mail these in or have them mailed to a location. So it just depends on the actual organization that you're working with. And they're typically conducted by partnerships with mass spectrometry testing. So it's very different than, say, a fentanyl test strip or a xylazine test strip. It's much more accurate. And it also provides opportunities to understand the other substances that may or may not be present within that specific sample. It also helps to understand some of those potency issues that Ellie was talking about. It is not typically associated with law enforcement. So this is a way for individuals who are using drugs, specifically those within communities, to find ways to understand what's going on with their supply locally hopefully before they utilize them, but also just the trends that they are seeing within their communities. So next slide. One of the locations that is present and one of the opportunities associated with this type of intervention, and I wouldn't even call this an intervention, it's really much more of a community-based organization and movement, is the Pennsylvania Groundhogs. And so these are street-level individuals who are bringing their substances to this organization, and they've been doing this since roughly about 2022 or so. And so what is really great about this organization is that they test for a wide variety of substances, both including adulterants that are psychoactive, but also those that are might be but that are non-active within the supply. And so you see here just the wide variety that can be active within a single supply. And so this is mostly within Pennsylvania. They do have some testing that goes on across the state of New Jersey as well. But you can, this is for drugs that are specifically sold as fentanyl. You see that medetomidine has risen and xylazine has decreased over the past several years. But we are seeing other types of substances, including specifically lidocaine, tetracaine, all the way down. And then, Ellie, if you can go to the next slide. To these very, what we would consider uncommon. But these uncommon types of substances may be indicators of what might be coming into the future. Next slide. This is for drugs that were sold specifically as cocaine. So we've really focused a lot on fentanyl and heroin, but cocaine continues to rise associated with overdose deaths. But a better indicator of what actually is occurring within the supply are some of these earlier testing experiences, because we know that the supply shifts so frequently. But not surprisingly, we see cocaine as the number one substance in here, but you'll also see lidocaine, caffeine. Caffeine is quite common as an adulterant, but you'll see methamphetamine all the way down to, you might have a small amount of these other substances, but you might also have a novel substance in there, bromazolam, spike unexpectedly. And so this helps to identify some of those issues that we might not be expecting within our supply, and very specifically thinking thoroughly around how it is that we can identify some of those, what we would consider shifting and changing patterns associated with the illicit supply. Next slide. And so we continuously see that fentanyl is the driving adulterant within the supply through the substances that have been checked by Pennsylvania groundhogs. But medetomidine has now officially overtaken xylazine, particularly within the sample that they've been taking. But we again see some of these other substances growing, changing. There's modification in this illicit supply over time. Next slide. We also take a look at some of the substances that have been checked in Prevention Point Pittsburgh. They've recently started doing a drug checking initiative. Importantly, so why are we talking a lot about Pennsylvania, Philadelphia, Pittsburgh? Because we unfortunately know that the substances that come in through the Port of Philadelphia tend to spread across all of New England and the Mid-Atlantic states. It is a major point and port of call for all these substances that come into our communities. In association with the other ports, including New York, as well as across the border in Canada. But we know that these substances have the potential then to spread through illicit networks and through personal networks. And so this is why it's important for us to be able to understand this as potentially as an early indicator. In Pittsburgh, we are seeing some of the same issues associated with the supply in Philadelphia, but perhaps in lesser extensive cases because of the way that the illicit supply moves across the state of Pennsylvania and across the various corridors. We do see fentanyl can continue to be the highest adulterant, particularly when you are expecting that you are getting heroin. This is a very small sample here, but we are seeing some of these other substances present within those specific cases. Ellie, next slide. And within fentanyl, we see local anesthetics, medetomidine, xylazine, BTMPS, again, growing just as what we've been talking about before. Next slide. Stephanie talked a little bit about some of the work that's going on with Brandeis. And what's really great about Brandeis is that it really does provide a good overview of what's occurring across multiple states, and particularly in the states that are up in the northern New England area, but across other locations as well, including Michigan and some other places out over in the Midwest. Again, noting here that you can explore these data, and there are available reports that are fairly real time associated with some of these things. One of the largest drawbacks of some of the official data sources is that it unfortunately has a large lag time. And so the data that we are looking at, even if it's an overdose death, may be a year, and some of those may even be longer than that before they're officially confirmed. Whereas some of these drug checking experiences may be almost real time. So, for example, the Pennsylvania drug checking through the Pennsylvania groundhogs is, I believe, updated almost daily, if not every other day. And so you have a much better understanding of the shifts and changes associated with the illicit supply. And so by utilizing these types of interventions, as we are, as I consider them, really thinking thoroughly around how it is that we can utilize these data in order to address and understand the changes in these patterns over time. And that brings me to the next slide, Ellie. This is where we have been focused in on a project up in the state of Vermont, thanks in large part to our partnership with the folks at NEHIDA and Stephanie. Um, and this is developing what we would consider an early warning system for substance use related issues. And there have been iterations of these types of experiences, Adam/Adam 2, the Dawn project, which unfortunately it looks like it is no longer being pursued through SAMHSA, given some of the federal regulations associated with shifts in policy. We have there's a national drug early warning system, but that's much more on a national scale. And the EU has utilized this as a mechanism for identifying novel psychoactive substances that have been infiltrating their illicit supply across various countries. But what this basically does is it identifies, monitors, and reports emerging trends and patterns in drug use, and it triangulates and cross-references a wide range of statistical and quantitative data in order to then identify alerts and where they may be spreading across geographic space and within personal social networks. Next slide. And so I think of this almost in the terms of weather, right? If we know roughly where a hurricane might be coming up through the country, and we can predict that based on various sources of data, and we have a given a confidence interval of where it may or may not go based on some of those data. And the same thing can be applied to our drug supply based on some of the issues and indicators that are present within our community. And this requires both some of those official sources of data, so national statistics, state-based statistics, but it also requires us to then coordinate those with some of those more real-time data, so drug checking and poison control center data, for example. Next slide. And so what we've been doing is identifying how it is that we might take this idea of a model and put it into practice for the state of Vermont. And specifically thinking thoroughly how it is that we can utilize machine learning and AI models, both in terms of predictive and analytics. So understanding where we might predict the harm to spread based on geographic patterns, but also then turning that into what we would consider prescriptive analytics. We are very familiar with alerts. I'm sure that we all get them when a set of overdoses are arising in our communities or across our states. But what happens when you get that alert, and what do you do with that information? This is going to help us to provide a little bit more of a translation of some of that data so that we can actually provide options for action, as well as prevent the spread of harms, again, through geographic networks as well as personal social networks. Next slide. So we've been heavily dedicated to this through my colleagues at Penn State University, Georgia Tech University, and now the University of Kentucky, where we have been training our AI and machine learning models in order to identify where these patterns may be shifting and changing and morphing over a geographic space. And so, next slide. As part of the second year of this work associated with this NSF project, we really focused in on identifying some of those official data sets. We are now, through the focus groups that we've been conducting in Vermont, identifying what other sources we may be able to utilize, including local information opportunities for connecting with folks who might be in your shoes, specifically in clinics, in hospitals, seeing patients, understanding some of the issues that are presenting themselves that may not be captured always within these official data sets. And frankly, might be in more real time. And so combining those two will be really important for us to then be able to provide more actionable alerts, opportunities for alerting the appropriate folks when they are potentially spreading to other locations. Because if we can identify that, yes, this spike is occurring within this one specific geographic location, but it might be spreading to yours, how might you then prevent and prepare for those types of experiences that might be occurring within your patient populations? And so that's what we are focusing in on right now. And so we're training our models for predictive and excuse me, predictive geographic spread of emerging harms, as well as connecting and developing opportunities for connecting with local sources of information. Next slide. So why does this all matter? Why do we, and I think that this group probably has a better understanding of why this does matter. And frankly, it's because we want to make sure that we are managing overdose, withdrawal, and substance use disorders in general more effectively. When we understand what's going on within the substances that our patients and our community members are utilizing, we have a better way of treating them both when they come into clinics, but also when they return into communities. It also might have implications for having multiple withdrawal syndromes that might be occurring at once. So when your patients may be presenting with different symptoms than what you might be expecting, it may be because your patients are utilizing substances that include adulterants that they were not expecting as well. These issues associated with tolerance and how that affects the actual individual is really important because of that potency issue that Ellie talked about. So these individuals may not necessarily understand the potency of the substances that they're utilizing, and that has direct impacts on their OUD treatment, but also strategies for managing withdrawal overall. And then finally, it helps us really to understand some of those complications of use. When we see novel adulterants, novel psychoactive substances, particularly emerging within the communities and within the illicit supply, we have to, again, address those in ways that will be holistic and hopefully address them in experiences that we may not have prepared for in general. Next slide. And so overall, what we hope that this presentation has helped to elucidate is that the illicit supply, frankly, impacts patients. And it will continue to impact patients because it shifts so dramatically and it has the potential to change drastically and momentarily. And so we want to make sure that we're thinking thoroughly around how it is that we address those immediate needs and acute issues associated with our patient populations. It also makes sure that we are thinking thoroughly around what patients may believe that they are using is not always reality. And this can complicate their treatment overall, both in terms of not non-psychoactive adulterants, but also novel psychoactive substances that may be present within the illicit supply. And one of the, I think, key parts here is that clinical trials really do have an opportunity to include illicit and street sources of substances for intervention development. The intervention that we're thinking thoroughly through about the development of our early warning system is a state-based intervention that has the potential to reduce harm over time, but that has the opportunity to then be turned into a clinical trial for comparative effectiveness across other locations. And so that's something that we're seeking out, but I think that there are much more opportunities here for additional opportunities for intervention development, deployment, and testing over time, including the complications associated with the changing illicit drug supply. And so with that, we will open it up for questions and happy to talk more broadly about some of the things that we've talked about here.
Thank you so much, Dr. Sterner. And wanted to open it up, as you said, to questions. You can feel free to unmute. You can raise your hand or just ask your question. I know we have one question in the chat that I could read out. We have a response, but maybe all three would like to respond to it. So our first question is, I have a relative who practices in Dallas, Texas, and they have no xylazine wounds there. I wonder if it is because xylazine isn't present, or do we know if there are other cofactors like other adulterants or climate that cause the wounds with xylazine in Vermont? So Stephanie, you had a nice response. See it in the chat. Others, any other thoughts on the wounds in particular?
I have to admit, I'm not familiar with the drug supply in Texas, but I imagine that drugs are imported from places other than where we're seeing our kind of drug flow in Vermont. And so my suspicion would be that there's probably just less xylazine in their drug supply, but it sounds like Stephanie's a bit more familiar with that.
In addition to that, some of the sources of the illicit supply differ based on geographic locations in the United States. We know that in the Northeast, particularly in the Philadelphia region, some of the issues associated with xylazine are also present within some of the sources of the substances that come through, for example, Puerto Rico. And so Puerto Rico has a longer history with having xylazine as an adulterant within particularly their illicit supply, but even before the what we would consider the opioid crisis or within heroin, it's been a known adulterant there for quite some time. And so through those illicit networks, we know that they have the potential to then pick up, unfortunately, some of those adulterants in the supply as they are moved through those geographic spaces.
Thank you. Oh, it looks like Gary, you have your hand up.
My hand is up. Okay. Why is my hand up? First of all, this was a really, really informative presentation. I learned a tremendous amount. One thing I was curious about is what are some of the principal determinants for what, is the actual composition of the illicit drug supply? It seems that it changes, and what are some of the driving factors?
I I think there's probably a complicated answer to that, but um, I
You can get
know
partial credit.
for example, I think one of the reasons that fentanyl has taken over heroin in the drug supply is um, money. It's much more potent. A small amount of it will make a lot of bags and you can make a lot of money as opposed to heroin where you need to have a field of poppies and extract it from the plant and process it and it's not very potent. So I think that's part of it. I think it probably is based on what adulterants are available. Um, and then like many of the adulterants we saw, they potentiate the effect of um, the active substance. So xylazine, for example, potentiates the fentanyl. It's cheap, relatively cheap, and so it kind of makes the fentanyl stretch a little bit further. So I imagine it's a combination of those things and what's available. And yeah, I think it's a complicated answer. Glenn or Stephanie, do you have insight into that?
One of the things that I will say, and I don't mean to highlight the practices of my colleagues in the criminal justice sphere, but that one of the ways that our law enforcement officers identify when an individual is either cutting or developing counterfeit, potentially pills, is by tracking the sources and the shipments of these various adulterants. And so sometimes those might be things like cellulose and experiences like that. Um, and so when you are tracking those and then targeting your investigations associated with those very specific adulterants, it then makes those individuals who are selling drugs and adulterating their substances shift, change, uh, and particularly those who are at the street level, try new things. And so the efforts of our law enforcement officers to solely focus on supply-based interventions uh, can actually drive some of this shift in the illicit supply as well.
Yeah, and just to piggyback on what both Ellie and Glenn said, definitely the economic factor, when you can do more for less, and that's definitely a big piece. On the supply side, with kind of the interdiction piece, yeah, like when you're having things replaced with these these novel substances that haven't had the opportunity to be scheduled yet. It kind of creates some loopholes there. And it also can come down to what that particular, what that avenue is. So like what that journey for those substances are, what particularly maybe a dealer dabbles in, so to speak, with what might be mixed or sort of co-utilized. I mean, I've been in this position for a little over 8 years now. And back then, when we were occasionally seeing cocaine with the opioid supply, at that point, we were like, this is cross-contamination. There was not the high level of involvement that we're seeing now, where we can say very, cut and dry, like this is intentional. Um, yeah, people get crafty.
Thank you. I have a question for my own. So it's part of my work at the UVM Center on Rural Addiction. I'm familiar with the harm reduction supplies of fentanyl test strips, and knowing that those are being shared widely across New England, for patients to use. And I'm excited about learning about this PA Groundhogs, that you shared. It sounds like a fantastic organization, and having that accessible to people who use drugs seems, like, fantastic. And so I'm curious about, in the Northeast, in Vermont. It sounds like you're very familiar and recently doing some projects there. Um, what what else is available for testing for all these adulterants, in addition to other drugs, that are accessible to patients, like in Vermont or across New England? What do we know about already out there?
There is that initiative through Brandeis University, and so there are multiple sites that are available for individuals who use drugs, as well as others who are associated with that project. And so um, that, I believe, has expanded even to multiple sites since its inception, and so it continues to grow. And so Brandeis University seems to be the best option at this current time. If there is interest in expanding some of this work, I know that the PA Groundhogs is looking specifically to reach out to additional states, and so they've just recently started in New Jersey. There is a location on their site to say, "Hey, I would like to bring this to my state," and there is an opportunity to work with that organization in order to do so and replicate some of those experiences across these other states that are dealing with similar issues as Pennsylvania.
Oh, and thank you, Kina, for
Oh.
posting in the chat there about a drug checking program in Maine. Fantastic. Thanks for sending that link. Um, any other
Oh, can I
thoughts?
just
Oh yeah, Stephanie, thank you.
I just wanted to add real quickly. I recently had a meeting with Dr. Green at Brandeis and found out that there are some additional testing strips that some of the programs are starting to use now. So the BT-MPS, medetomidine, we have some nitazene test strips as well. So they are working to get those out into the programs as well, trying to. Brandeis has done a lot of work around the efficacy of the test strips, making sure that they actually test the way that they should. So those are some things that are also getting out within the different programs, and um, that's fantastic. I know that Brandeis has also been doing some work with the folks up in Maine, so it's great. I think the better picture we have and the more testing we have across the region, the better off we all are.
And I do know that there is interest in exploring that, that community-based model for drug testing into examining clinical-based outcomes. And so I think that this group, and there are some discussions that I've had with the folks there about how we might actually interventionalize it, so manualize it, develop it for implementation in other locations, and then test its impact on patient level as well as public health outcomes over time. And so I think that that's a clear need here because uh, we all know that funding is tight, and we know that funding availability is limited, particularly in the harm reduction space at this stage. And so if we really want to make sure that individuals are safe when they're utilizing their substances, this is a way to show clinical outcomes associated with some of these community-based interventions.
Thank you. All right, we'll give Gary the last question.
Okay, and just building on what you had just shared with us, Glenn. Do current NIH guidelines, restrictions, and priorities, how are these impacting on capabilities to be able to go ahead and to investigate what are some of the more optimal approaches that can be taken to treatment, and where are we sort of being cut off at this point?
Well, I alluded to this, but harm reduction is drastically being cut, particularly through the NIH, but also through places like SAMHSA and other federal sources. And so there are alternate options that we are exploring specifically through foundations and philanthropy, but everybody's doing the same thing. And so it really highlights the need for evidence-based practice and having clear analytical strategies that will show that the interventions that we're developing, the information that we're utilizing for those interventions need to make sure that they are coming from research and that they can turn into research for an intervention that can be deployed. And so the more that we can utilize our expertise collectively, particularly among this group, I think the better.
And I think it's very important to be able to increase confidence in science, which I think in a number of cases is eroding. So that's very key. Messaging is more important than ever before.
Agreed.
Thanks so much. Thank you again to our presenters and to the NNECTR for hosting the presentation. And look to the website to find this recording.